Can you imagine how depressing is it when your life is suddenly ravaged by a rare brain disease? Let's talk about encephalitis, a potentially devastating brain inflammation. This is Sheila, a second-year internal medicine resident from St. Vincent Hospital, Worcester. I have a 61-year-old gentleman with no significant past medical history who was brought to the emergency department for acute onset confusion. While in the ED, his mental status was worsening and he developed generalized tonic-clonic seizures. Physical examination was not suggestive of any focal neurological deficits. Initial evaluations including blood works, CT head, and MRI brain was within normal limits. A lumbar puncture was performed and it was suggestive of normal CSF pattern. He was started on acyclovir to cover for possible herpes encephalitis while awaiting for CSF microbiological data. Earlier in the course, herpes encephalitis can have a similar presentation as I mentioned above with normal CSF profile. Herpes PCR is the gold standard for diagnosis of herpes encephalitis with a sensitivity of 98% and specificity of 99%. His mental status continues to worsen and he was requiring maximum doses of Keppra, valproate and lacosamide to control seizures. However, herpes PCR along with other viral, fungal and bacterial studies came back negative and acyclovir was discontinued. He was started on steroids and an MRI was repeated. It was showing T2 flare hyperintensity in the bilateral medial temporal lobe. These MRI findings are sensitive for limbic encephalitis. Briefly, limbic encephalitis refers to an inflammatory process localized to structures of the limbic system, although the pathologic, clinical, and radiologic findings are often not confined to these areas. It is considered as a classic paraneoplastic syndrome, defined as a disorder that is commonly due to paraneoplastic process. And it is also one of the main manifestations of the several of autoimmune encephalitis syndrome that may occur without a cancer association. So we performed an age-appropriate cancer screening and autoimmune workup in our patient and it was within normal limits. He was started on plasmapheresis and in total he received 7 sessions of plasmapheresis. His seizure was better controlled and we were able to decrease the dose of the seizure medication. Post-discharge, he had significant improvement in the mental status, though he still have minor deficits in the short-term memory and executive function. MRI brain post-discharge was showing mild atrophy of the bilateral hippocampi. Early identification and treatment initiation can be a key factor in halting the progression of the disease and morbidity. Initial treatment with plasmapheresis or IV immunoglobulins and maintenance with immunotherapy can be beneficial. However, there is limited literature on diagnostic and therapeutic interventions. It was once pointed out by Dr. H. Gordon Dean of the Mayo Clinic, an expert in encephalitis, that the disease is so hard to study because it's so rare that even the largest medical centers see very few cases. Let's hope that with technological advancement and brilliant minds at work, we will once conquer this disease. Thank you.